Ah, thank you. Magic. So I'm Ernest Moy. I'm from the Agency for Healthcare Research and Quality. And so, well, we're mostly a research organization, but maybe you can find something in the things that we do that are relevant. We're the part of HHS that's charged with improving healthcare quality for all Americans. And the All Americans is our commitment to disparities. And because nurses are the dominant healthcare provider in the nation, we think that we do have relevance to you all. What you see here is the two reports that I mostly work on, the National Healthcare Quality Report and Disparities Reports, and they just go up on my front slide because everything I do at least relates to them in some way. And I'm going to talk a little bit about the 3Ds in that context. Like a good researcher, I couldn't just talk about the 3Ds. I had to think in my mind, like, how did they relate to each other? I think we intuitively think they relate to each other, but I felt obligated to create some kind of organizational model. And this is how I think they relate to each other. Hey, I'm from ARC. So I think we know that the social determinants are critically influence health and healthcare. You know, the environment that we live in obviously impacts the health that we have and the healthcare that we're able to access. And of course, I had to break it up because I'm a splitter. And I divide into two components. They're the personal resources that a person has access to, and this is kind of the household environment. You know, what kind of financial resources you have in your household to help you deal with health and healthcare, as well as the non-financial aspects. Perhaps a person in your family is educated and can help with healthcare decision making, and in another household that might not be true, and they might lack those non-financial assets. So that's one component, I think, of the social determinants. And the other component, of course, is that the broader community and its resources also impacts health and access to healthcare. Having healthcare providers in your community, as well as having access to grocery stores that provide good food and the ability to exercise, obviously all impact on your ability to maintain health and to access healthcare. Then the other side, we have workforce diversity. And I think the workforce obviously impacts health disparities in a huge way. And I think, at least in my mind, the primary mediator is patient-provider interaction. And I think as we have a more diverse workforce, people can then go and shop around and find a provider that they feel that they can trust and they can communicate well with. And then the flip side of that, when we don't have workforce diversity, everyone has to go to the same kind of provider, and they might not necessarily get the best healthcare that way. So I see patient-provider interaction as a mediator between diversity and health disparities. And what I'm going to do today is try to very quickly talk about what ARC does in each of these different boxes. Okay, so the bad news. The bad news is we don't do all that much in workforce diversity. I was reminiscing with Dr. Neve when he was here earlier that we actually used to work with WMC and have a health services research institute, which was geared towards developing minority health services researchers. And sometime in the last 10 years or so, that kind of fell apart. But maybe we'll think about, doing something in that area again. But unfortunately, at this moment, I'd say that we don't do all that much. But one of the things we do is we track. And so one of the things that we track in the National Healthcare Disparities Report is diversity of the workforce. And what we do is we rotate through the different healthcare providers. And a couple of years ago, we looked at nurses. And I think not terribly surprising, that the bar on the left is the racial distribution of RNs. And the one on the right is U.S. population. And you see that minorities typically are underrepresented in that distribution. And then the intermediate column there, I have LPNs and LVNs. And we see a slightly different pattern there. We do actually see that among some minority groups, they are well represented among that group. I'll say this isn't just unique to nursing. And so here is another workforce diversity thing that we tracked, which is dental providers. And you see among dentists and dental hygienists, for instance, minority dental providers are underrepresented, but then you see among dental assistants, for instance, different minority providers are well represented. And I was going to put it out here, even though it's probably controversial, and I know I warned everybody about this, that maybe one of the ways to kind of deal with the lack of minority RNs and well-trained dental providers is to work with the LPN, LVN, and retrain them, and then you don't have to worry about the whole pipeline kind of issues that exist out there. And similarly among the dental providers, maybe dental assistants can be upgraded to function as dental hygienists. I throw that out there for you to think about. Not my area of expertise, just an observation. We think we do a lot in the area of patient-provider interaction. So we do a lot of research and measurement stuff. And so we're the home of the CAPS. So this is the survey, the consumer assessment of health plans, surveys, and everything like that. They basically capture different patients' experiences of care. And in that CAPS survey, there are patient-provider communication questions. And recently we developed specific item sets that focused on issues of cultural competency and health literacy. So we try to put out the tools there that are important for capturing the patient-provider interaction and communication, and that one then can use to study, does diversity actually improve communication? Does it lead to better health? We also put out a number of health literacy measurement tools, and I list 2 of them there, not my area of expertise, but they are meant to be short, one-page kind of documents to assess a patient's health literacy. But then on the very bottom is, despite all that, one of our conclusions is that the best thing to do is when patients come to you, assume that they don't know what you're talking about. And so we have a health literacy universal precautions toolkit, which just like with bloodborne precautions, you treat all potential bloodborne exposure as potentially hazardous. Similarly, we treat all patient-provider interactions as if the patient needs special attention to understanding what you have to say, and that's the health literacy universal precautions toolkit. Okay, I'm going to move now over to the social determinants realm. And first I'll start by talking about elements that relate to the household environment. And one of the things that we do extensively all through the reports is we look at the impact of different socioeconomic variables on people's health and healthcare. This happens to be related to quality of care for diabetes, and we see the very strong impact of income, education, insurance status, etc., in addition to race and ethnicity. In this particular measure, you want this kind of services. The higher the bar, the better you are, and the lower the bar, you're disadvantaged. And also on the access side, we see something similar. So this is availability of health insurance among individuals age 18 to 64. And again, you see the very, very strong socioeconomic effects there, the very strong determining effect of social factors. And I think we put it out there in the hopes that people can use these kinds of contrasts to target interventions for different populations. This helps one identify which populations are in greatest need, and perhaps we can target resources to those populations. The other way of looking at social determinants steps back a little bit broader, and so we've done a lot of work looking at community resources, specifically at variations across different communities, and this is again coming out of the Disparities report. And we take all the measures that we tracked in the report, about 200 odd measures, and we mush them all together, and then we rank the different states based upon the level of quality it's achieved. And this is just to show that there's a lot of variation across the states in overall quality of care achieved. We also do work that focuses on the disparities element. This is income-related disparity, and so we just look at the difference in care received by high-income and low-income populations, and again, sort them by the exact same thing. And I'll make one quick observation, is that the maps don't match exactly. And this might be relevant to some of the work that you do, which is that there are some states where there's high quality, but there's still large disparities. And in those states, you might have a focus on improving the disparities and not necessarily quality. In other states, you might have the two tracking in parallel. You might want to try to improve quality of care for everybody. And this allows us, I think, to target interventions that are unique and specific to different kinds of communities. And I will also mention very quickly that we have a special product that we put out there looking at state variation called the State Snapshots. We take every state, in this particular case Virginia, and show how they're doing compared to all the other states for a wide variety of different quality measures. And that might be just something that you would look at this issue of community resources and that impacting on the health and healthcare that people receive. Another way that we look at community resources is assessing the quality of the safety net, and this is some work we did recently. There's been a lot of media attention to emergency room use for dental conditions, and this looks at emergency room use for dental conditions, the rates, that's what you're seeing as the bars, as a function of the patient to dentist ratio. So on the right, you have a large number of patients being served by a dentist, and on the left you have a small number, and not terribly surprisingly, but interesting, you see that there is a relationship in those communities where you have few dentists, you have higher rates of use of the emergency department for dental conditions. And then disparities. So we do a lot of tracking of disparities. So in the quality and disparities report, we summarize across all our measures, and we add it up. And in the green bar, green part of the bar, you see the proportion of measures where a particular population does worse than the comparison population. The blue is when they're about the same, and the black is when they're doing better. and roughly across almost all the populations that we track, roughly between 30, 40, and 50% of measures, the disadvantaged population does worse. And so disparities are very evident, not hard to find. We look at variation in disparities across different geographic areas, in this particular case, states, and you see again that there are huge variation in the difference in care received by different populations. Again, this one I think is the high income versus low income populations. And we look at healthcare disparities costs. We try to quantify. In this particular case, we're focusing on hospitalizations that are potentially preventable by good quality care delivered often by nurses. And we quantify that, if you look at it by race ethnicity, or if you look at it by income, it's about $10.5 billion a year that is accountable for differences in rates of these avoidable hospitalizations across populations. So there's a lot of money there that could potentially be saved if we got our hands around this disparities problem. And then lastly, we try to look at disparities over time, what's getting better and what's getting worse. And here, again, this is a sorting of the different measures and their distribution, and the blue I'll focus on are those measures where there is not a change in disparities. And across the whole population, contrast that we typically track, the vast majority of things are not changing at all. Things are not getting better, even as overall quality improves for everybody. So, a quick summary, what do we do related to the 3Ds? We measure and track workforce diversity, and we target improvement practices for the patient-provider interaction aspect. We work in the area of social determinants, mostly trying to target populations and communities for different interventions. We also do some assessments of the safety net. And lastly, in the reports, we do a lot of research as well as quantifying and tracking of healthcare disparities. Thank you.